Welcome back to the deep dive. Today we're peeling back the layers on a story that starts with a single patient. A really tragic diagnosis, but it quickly spirals into this fierce critique of healthcare policy.
Right, and social fairness. This deep dive is aimed right at that intersection between, cutting-edge clinical science and the bureaucracy that can sometimes get in the way.
Exactly.
We have a really compelling stack of sources here. They detail a case study that, well, it focuses on one person, but it just lays bare this huge systemic flaw in Taiwan's national health insurance system.
And the stakes couldn't be higher.
No, this is about life, death, and whether your zip code basically determines your chance of survival.
Okay, let's unpack this. Our mission here is to really analyze the documents around this young lung cancer patient's very confusing clinical journey.
Right.
We need to connect the dots between the need for advanced diagnostics, we're talking about next-generation sequencing, and how that runs headfirst into these really rigid hospital rules.
Yeah, the goal is to understand exactly how those policies create this unfair divide. We're looking at a system where your ability to get life-saving information literally depends on where you live.
Or which hospital you walk into.
Precisely.
So let's start with the patient herself, just to establish the clinical stakes. Our sources introduce a 29-year-old woman.
And a non-smoker, which is a critical detail here.
Absolutely. Her symptoms were severe and getting worse, a persistent cough, shortness of breath so bad it would wake her up at night. The source material, it actually describes her life as having gradually collapsed.
It's devastating. And the initial findings, they just confirmed how bad it was. Imaging showed both her lungs were filled with what's called ground glass infiltration.
And the biopsy.
It confirmed the diagnosis.
Yeah.
Lung adenocarcinoma.
But we have to pause on the biopsy detail for a second because this is so central to the whole policy debate.
Okay.
These chest biopsies, they're computer-guided, and they provide a tiny, tiny amount of tissue. It's a precious and very finite resource. So she's incredibly sick. You have a very limited tissue sample, and the clock is ticking. The doctor needs to act fast. What was the first move?
Well, the first physician went with afatinib. It's a targeted therapy.
And why that one?
It was a decision based on clinical probability. She's a non-smoker, so statistically, the most likely driver mutation is EGFR.
Epidermal growth factor receptor.
Exactly. And afatinib is the standard drug for that. With her level of respiratory distress, they just couldn't afford to wait. It was a logical, calculated first move.
And for a minute there, it seemed like the right one.
It did. The source says her symptoms slightly improved.
And there was more. Later, when she saw the specialist in our materials, they found swollen lymph nodes in her neck.
Right.
But while they were preparing for a full body scan, those neck nodes actually started to shrink.
Which would tell any doctor, okay, this drug is working, at least, partially.
Exactly. And that partial success, that's the trap, isn't it?
It's the ultimate diagnostic trap. It gave this dangerously misleading sense of control, like they were on the right path.
Here's where it gets really interesting and honestly pretty horrifying. How could the drug seem to be working locally, shrinking those nodes, while the cancer was running wild somewhere else?
Well, the full scan gave the answer, and it was shocking. A brain MRI revealed she had at least 10 metastatic tumors.
10?
At least 10. So despite that partial local success, the real underlying driver was just fueling this massive spread to her brain. This is the moment where everything falls apart.
And the life-saving window was closing. Fast.
Very fast.
Which brings us to the thing that saved her life. She was lucky enough to finally get access to next-generation sequencing, NGS.
Right. And it just completely changed the entire picture.
Explain what NGS does that's so different.
Well, NGS it's a revolutionary tool because you don't have to guess. You don't have to test for one gene, wait, then test for another. It screens for hundreds of potential mutations all at once.
Using that same tiny tissue sample.
Exactly. And what it found here was complex.
Right.
And a total game changer. It showed she had multiple mutations. But the main one, the primary driver, was an ALK-EML4 fusion.
Not EGFR.
No. I mean, yes, she had a secondary EGFR mutation, but only at about 40% expression. The real engine of this aggressive cancer was ALK.
So the afatinib was working just enough on that 40% EGFR to shrink the neck nodes.
Right.
While the ALK-driven cancer was untouched and just exploding in her brain.
Precisely. The second they identified that ALK was the primary driver, they had to switch treatments immediately to an ALK-targeted drug.
The implication there is just massive. If they
Yeah.
had stayed on the EGFR drug.
The ALK-driven cancer would have just continued its aggressive spread completely unchecked. Her survival, I mean, it really hinged on getting that complete picture.
And what's fascinating here is you see why sequential testing is just clinically impossible in a case like this.
You really do.
If that first doctor had stuck to the standard pass test for EGFR, wait for the results, then test for ALK, you hit two catastrophic problems. First, the time.
The time wasted is just, it's devastating. You're letting the cancer progress, just like we saw with the brain metastases.
And second, you said the tissue sample was finite.
And you waste it. You use up that tiny biopsy sample on one test, then another, and you could easily run out of tissue before you even find the true driver. NGS is really the only responsible option.
It seems like a no-brainer then. If NGS is the gold standard for these complex cases, why isn't every patient getting it?
And that's where we pivot from the clinical reality to the policy nightmare. The institutional barrier is all in the NHI regulations.
What's the specific rule?
The sticking point is a rule that says the hospital must be qualified to open the inspection order of the test.
What does that actually mean, qualified? Is it about money? A certified lab?
It's mostly an administrative tiering system. It's based on the hospital's status, which is often tied to its internal lab capabilities.
So wait, even the best oncologist in a regional hospital could be blocked from ordering the test.
That's it exactly. They are institutionally barred from ordering it because the building they work in lacks the right administrative clearance. It has nothing to do with the patient's need or the doctor's expertise.
The power is tied to the facility, not the specialists.
Yes, and that is the source of this geographical divide that our source documents are so critical of.
So let's lay out the two scenarios they describe, because this really dramatizes the unfairness.
Contrast is damning. Okay, scenario 1. Imagine this patient is in a rural area, let's say Taitung.
Somewhere without a big top-tier medical center.
Right. Because of that hospital eligibility rule, her doctor would be forced down that sequential single-gene testing path.
The very path we just established is misleading and wastes tissue.
Exactly. She'd likely get a partial diagnosis of EGFR positive, or they'd exhaust the tissue sample before ever finding the ALK fusion. She would miss her treatment window, period.
And now, scenario 2, the one that actually happened.
The patient is in a major city like Taipei. Her specialist can order NGS because the hospital has the right bureaucratic qualification.
It's the same patient, same cancer, but a totally different outcome based on location.
It is tragic inequity. The source calls it institutional unfairness, not just a delay. The administrative structure itself directly deprived the rights of patients in remote areas.
So the system is essentially creating these exclusion zones. Urban patients get the full, comprehensive testing.
And rural patients are denied that same life-saving chance because of paperwork.
Which really begs the question, is the NHI inadvertently rationing survival? If access to a technology that makes the difference between life and death is gated by geography and hospital status.
It certainly looks that way. The system seems to favor administrative convenience over a patient's urgent need for an accurate diagnosis.
That brings us to the call for reform. The sources don't just point out the problem, they propose very specific fixes.
Yes, and they frame it as a social fairness issue, not just a healthcare tweak.
So what's the first proposal?
The fixes are all targeted at unbundling the doctor's expertise from the hospital's administrative rank. So first, the NHI has to revise the rules to empower the individual specialist physicians to order NGS.
Regardless of the hospital's status.
Regardless, the clinical decision has to rest with the expert treating the cancer, not the building's rating.
The expertise should travel with the doctor, not stay stuck to the building's zip code. What about the money side of it? You mentioned even when NGS can be ordered, the payment is an issue.
That's the second crucial point. The reimbursement is, frankly, wildly inadequate. The NHI currently gives only a symbolic 10,000 points for these tests.
What does 10,000 points translate to?
Well, it's understood by physicians to cover only a tiny fraction of the actual cost of running an NGS test. We're talking expensive equipment, reagents, specialized staff.
So the NHI is essentially saying, you can do the test, but we're only going to pay you a pittance for it.
Right. Which discourages smaller centers from adopting it because they just can't absorb that financial loss. The reimbursement has to be reasonable. It has to reflect the real cost and value of the technology.
Otherwise, it's still a barrier, even if it's allowed on paper.
Exactly.
And the final overarching principle, the big idea behind these changes?
That policy has to be patient-centric, fundamentally. The rules need to stop focusing on administrative convenience and start focusing on maximizing a patient's chance to survive.
Hey, to summarize the stakes here, every patient, whether they live in Taipei or Taitung, deserves the exact same opportunity for a correct diagnosis.
They deserve equitable access to the information needed to save their lives. The story of this 29-year-old, it just reflects a fundamental flaw where geography determined everything. And that flaw has to be fixed.
So what does this all mean for you, listening to this? The whole discussion, it hinged on the fact that the initial treatment seemed to be working. Those lymph nodes were shrinking, even as this aggressive cancer was sending 10 tumors to her brain.
That partial response is the real danger zone. When policy restricts you to single gene testing, you risk getting just enough positive feedback, like those shrinking nodes, to think you're on the right track.
While you're actually masking a catastrophe.
Precisely.
So the system failed not just by denying access to NGS in some places, it failed by making the limited sequential testing it does allow inherently misleading in a complex case like this.
That's a powerful way to put it.
If a partial misleading response to the wrong drug can hide metastatic progression, you have to ask, how many other patients are being put at severe risk just because policy is limiting their doctor's access to the right tests? That's something to really mull over when we think about the hidden costs of these administrative lines we draw in healthcare.
A critical question. For everyone, thank you for joining us for this deep dive.
We hope this gave you the context you need to understand this urgent call for reform. We'll see you next time.